Yeah. So Dr. Kashyap Patel is a Wellcome Trust Career Development Fellow and consultant physician in diabetes and endocrinology. His main area of research includes understanding the genetics of diabetes with a focus on monogenic and type 1 diabetes. He was a Wellcome Trust PhD Research Fellow in prestigious MRC 14 Phosphorylation Unit in Dundee, where he was awarded his PhD studying the glucose metabolism in liver. He is the recipient of prestigious Young Investigator Awards from Diabetes UK. So over to Dr. Kashyap Patel. And as you know, we have 15 minutes time for your talk and 5 minutes for discussion. Dr. Kashyap Patel, please.
Thank you very much. Let me share my screen. Okay, can you see me? My slides okay?
Yeah, yeah.
And can you see the mouse, the pointer?
Yeah.
Brilliant. Okay, so good afternoon, everyone, and thank you for the introduction. I'd like to thank Dr. Sabu Bansiji for invitation. So really, next 15 minutes, I'm going to talk about monogenic diabetes, and really, this is a diabetes where people think this is not in my clinic. You know, everyone says, "Oh, I have this is not for me. It's too rare." But let me tell you this: that it is the diagnosis. If you make it, you're gonna make huge impact on your patient um, for lifelong. So when we really talk about um, monogenic diabetes, what I really mean is a diabetes due to a single gene defect. And there are lots of different words out there, but on it's essentially a genetic forms of diabetes. It can be either due to what we call a heterozygous mutation, so where you have a normal allele on DNA1, and then you have another one which is mutated, so you call heterozygous or dominant forms of diabetes you get because of this. Or really, you can have both alleles of DNA has been mutated, which is what we know is a recessive mutation, and is often seen when the parents are consanguineously married. And really, if you want to put them in a some sort of categories, these diabetes, you can broadly put them in three different ones. The one we call them neonatal diabetes. This is a diabetes essentially described as the one someone get diabetes under the age of 6 months. So really purely based on age. It is rare, and we have done a lot of work in Exeter, and we now know at least 27 different genes causing this type of diabetes. The second one, which I'm sure a lot of people are aware of it, are called MODY, which is a maturity onset diabetes of the young. Now, the MODY is essentially a physical description of diabetes, which was done many years ago in 1974 by Robert Tattersall in Oxford in the UK. And essentially, it is a non-insulin dependent diabetes which presents under the age of 25 and has a dominant history of diabetes. It's about 11 gene causing these, and if you think it is rare, think again, because we have done some population studies in the UK, and I've done some in Turkey, and we know that is about 3% of clinic, 3% of your patient with diabetes under age 30. And there are certain tips I'm going to give it to you to increase that number to nearly half of them. The patient you see might have a MODY. And then finally, which I really like to group them, is the recessively inherited ones. Again, you might have come across this. Is often seen in the young pediatric patients, but they have insulin-dependent diabetes, but often they have some extrapancreatic features. And one of the really the famous example of that is a Wolfram syndrome. And really, what I think is monogenic diabetes is like detective work. In the UK, you might say it's a Sherlock Holmes, but this is my favorite character, Byomkesh Bakshi. I know people with my age might remember in 90s, 97, I think, it came on. Wonderful series. It's really about observing your patients and really just taking in history. And that is the biggest clue you can get, finding those elusive monogenic diabetes patients. And actually, and I'm gonna get you through a few cases just to kind of get feel for it and what I'm trying to say here. So this is MP. He's 18 years of age now, and he diagnosed with diabetes at 3 months, and he's really ill at that time. He has been treated for last 18 years as type 1 diabetes and with insulin, and he had an extremely terrible time. Uh, Hypoglycemia all over the place, glucose high, low. I mean, this life of him and his parents were really very, very poor. If you measure C peptide, he was not making any. So what we call describe this is that MP has something called neonatal diabetes. So when did we kind of think about it being a monogenic diabetes? Well, this is the most important data, which kind of first suggested that something is quite odd about the people who get diabetes under 6 months. So what you have here is a high risk type 1 diabetes HLA distribution in the people who are normal. So you get about 30% background rate. And what was interesting is that those under 6 months of age, they had a similar level of type 1 associated risk alleles as the people who were normal. And as soon as you kind of looked at the people diagnosed after, suddenly they get high risk HLA allele increased, which is inconsistent with type 1 diabetes. So that was the clue that something, those under 6 months, is not a type 1 diabetes. And indeed, Lisa DiFranco, Nexusa did the wonderful work over last many years, and we sequenced nearly 1,000 patients with the neonatal diabetes coming from more than 76 countries. Now, this number at the moment is 99. And we know that they're caused by roughly 27 genes. Depending upon which background you come from, if you're a consanguineous pedigree, you get a different sort of gene mixture compared to from non-consanguineous ones. But what is clear was that at least more than 80, and now this data is all in 2015, and we haven't published the updated one, but right now we get diagnoses for 90% of people who get diabetes under 6 months. And one of the exciting finding of this one was these two little genes you can see at the bottom, which is a KCNG11 and ABCC8. Now, those genes are the genes forms what we call KTP channel. Now, KTP channel, you all aware, is really the binding site for well-known drug sulfonylureas. We use it left, right, and center for many, many years. So essentially what happens in these patients is that when they have a mutation in this one of these genes, which forms these subunits of KTP channels, essentially they don't respond to these high ATP levels, which happens in normal beta cells because of metabolism. And because they don't respond, you don't get depolarization and you don't get insulin secretion. So you basically essentially get diabetes. So once I think Andrew identified this back in 2004, it was very clear that the best way to treat them is use sulfonylureas because essentially it closes the channel. And that's exactly what happened, that when you put sulfonylureas, it closes the channel, it depolarizes the membrane, and you get insulin secretion. So not only we found the reason for diabetes, we also found the treatment. And that was such an exciting finding, and it has a massive impact in people's life. So left end of the panel here, what you're seeing is that the study done by Ewan Pearson when he was in Exeter, that took people who were on insulin with a mutation in the KCNG11, so that is that KTP channel, and then he took the insulin off and put entirely of those children, or in some cases adults, were on sulfonylurea, and you can see that all came off and they had a better glycemic control. You can look at some traces of the glucose. This is the single individual patients who were on insulin pump, and then after glibenclamide, you can see how tightly the glucose is controlled. And that's exactly what we did. But one of the things I'm sure you might have noticed is the dose I put here for glibenclamide. Now, so basically, JM had a mutation in KCNG11, so he then went on with the glibenclamide treatment. Now, what is the fascinating biology here is that these people need really high dose of glibenclamide. So about 3 to 5-fold than what we use in type 2 diabetes. And on average, they need about 0.5 to 0.8 milligram per kilogram per day. And they don't really get any side effects. They don't get any severe hypoglycemias. But what really they get is that their life is transformed. They completely come off of the insulin, no more testing, no more hypos. They can do any exercise, diet, anything you want. Any trips abroad or vacations, sleepovers, cricket, which he used to love, he went back in it. And his life was completely transformed. So it was just a simple question. When do you get your diabetes? And if you just ask that question, you found those patients in your clinic. How long the effect of this treatment last? Well, the PALM in Exeter followed some of those patients for up to 10 years and showed that actually 94% of people who had the mutation in KCNG11 actually maintained on sulfonylurea. Only 6% who had to have some insulin treatment, and they almost all required some basal insulin in addition to sulfonylureas. And here is their long-term control, and you can see before on insulin and then sulfonylureas, and for 10 years their HbA1c remained exactly the same. And this is the dose of their sulfonylureas. And as I said, it's roughly about 0.4 to 0.2 they need for the life. So it is not only useful that particular time, but the effect lasts for 10 years. And I'm sure the longer data will go on, we'll have a better understanding. And particularly, I'm predicting that almost all will respond for many years. So this is my take-home message one. If you really want to find your diabetes, ask one single question. It's like Böhmke's Bugsy, nothing fancy, just ask, when do you get diabetes? If they got under 6 months, the answer would be always do genetic testing, because 40% of those children would have this mutation in KTP, and if you find those, you can transform their life. But remember, they need a high dose of sulfonylureas. Now, the good thing is that we offer in Exeter the free testing for any kids who diagnosed under 6 months on a research basis. So if you have those patients, you can write to me, or you can go on a website and you can send the patient's blood to us, and we will do the testing for you. Okay, so let me talk about the second patient. Now, this is a slightly patient which you will come across more often than not. He is a JN, he's 34 now. He's got diabetes when he was 19. His BMI was 22, so wasn't particularly heavy, not even from the South Asian BMI point of view. He was treated as type 1 from diagnosis on an insulin basal bolus therapy, and the HbA1c was not great. What was interesting is when you kind of talk about this patient a bit more, you realize that actually he was missing insulin, but he wasn't getting the DKA or having any problems. And then you kind of did more digging, and you find out that his mother and his maternal grandmother also had diabetes. So really, what type of diabetes he's got? On the face of it, is a bread and butter type 1 diabetes, but is it really? He's got some family histories there. He's missing insulin without any problem. He was could it be type 2? Well, probably less likely with the BMI, even with the South Asian standard, as I said. What about monogenic diabetes? Now, this can be MODY, as you can describe. It's a thin, it's an early onset, and it's got dominant history. So how do you really pick the people for genetic testing? What things can help you?
Well, it's a very interesting thing, but your time is almost over. So if you
is it 15 minutes already?
Yeah. So, but you can take another 2 minutes to,
Because I thought I started at 12:18 on my clock here. Okay, so well, basically you got two things to do. One, which is the peptide, which you can do, which can help you type 1 and MODY. Or second thing you can do is you can actually do antibodies, which is hardly ever seen in MODY patients. So you can really use them to exclude patients from genetic testing. If they don't have antibodies, this is the new test we develop in Exeter, where you can test their common genetic risk and help you to discriminate between type 1 and MODY. So I'm going to stop that. I'm going to show you that he basically had 1 alpha MODY, HNF1 alpha MODY. He was antibody negative and a lot of C-peptide. And how do you treat them? Well, you can treat them with low dose sulfonylurea. So this is the only randomized trials which shows that the people with HNF1 alpha MODY were 5 times more sensitive to sulfonylureas. If you have another type of mutation which we call glucokinase MODY, that don't need any treatment. So essentially, it does matter. He came off from insulin and his control was much, much better. So this is the second take-home message. I'm going to stop there. Is that if you have a patient who is normal weight, had a family history of diabetes, particularly the HbA1c at diagnosis was not as high as we shown in recent study, And if they're non-insulin treated, yeah, you really have to suspect MODY in those cases. But if they're insulin treated, but they have this lack of antibodies and C-peptide, then those ones you must consider MODY. If you find 1-alpha and 4-alpha MODY, then they need the low dose treatment. You stop insulin completely. And if they have a glucokinase MODY, then doesn't need any treatment really. And I'm going to stop there. And I'm just going to say to you that in conclusion, really all you need is a simple history. If they have neonatal diabetes, they definitely need a genetic testing. If they have a MODY, which filling in certain simple criteria, you can consider MODY. And then finally is the recessive, which I didn't have time for today. Sorry about that. Where if you have a young onset diabetes with any additional features, then they also need a testing, and both of these we offer in Exeter on a research basis. So feel free to contact me anytime, and I'm happy to help you on those. So I'd like to thank the organizers, particularly Bansiji, for the invitation, my mentor, Andrew Hattersley, and all the team we have in Exeter. Thank you very much.